Let me know in time. If our DTO is missing, then we'll skip him and move ahead.
Yes.
And with this, very good evening, DTOs. बहुत स्वागत है आपका from all parts of India. And before I start the day, my good wishes to the people in Northeast, all these 7 sisters. I know it is raining very badly there. Floods are there. So the good wishes from the entire team. We all over from India, we are logged in here from north to south and east to west. So our good wishes to you, and our good wishes to Mizoram, where it has not been raining at all. The kind of rain that Mizoram should have been seeing. So with this, Dr. Manoj, welcome. Good morning. How's the weather in US?
Good morning. It's very hot and muggy in the south, and lots of rains and torrential stuff going on in the west. Really amazing how the weather has overtaken so much of what we, do and talk about these days. It's very strange weather all over.
Yes.
Absolutely. And that is the reason I was giving good wishes. And the best part is that Dr. Easter from Meghalaya is joined with us. And Meghalaya, Megh. The name of the state is on rains, and it is raining quite badly there. And Dr. Kaushik from Assam is also trying to join. Assam is in the worst state of floods right now. So details, I am very excited today actually. And I wanted my excitement to reverberate in this virtual room. And I wanted all of you to feel this excitement. And the excitement, the reason is that, we had a vision of this BTN 3 months back. And today it is unfolding precisely with the DTOs presenting their PDSAs. Okay, we will see how we are looking at the problem logically, and how some bit of behavioral change or thinking change is taking shape in us. So today is a very remarkable day. 65 youths were trained from all over the country. They are on your screen right now. Okay, hesitant, apprehensive youth, but they have been in touch with you for the past 1 month, holding your hands, discussing with you, conducting meetings with you. These have been trained and they are convinced, and they will be there all across the country. They will definitely live 4 times more than what our age is right now, and they will continue to bring benefit and marvelous things long after we have gone. So that's one more reason to be very happy about. More than 350 DTOs participating in the program to the tune of approximately 400. That much is the kind of work which is happening right now, all from this small screen on your laptop and your mobiles. So what a remarkable day. So together we will, and together we shall. Only thing is that I would also like to say my DTOs have, my team leads and counselors have specially requested that I must share with you that, the certificate at the end of this training is also very important. Okay, the certificate which will be signed by CTD, by CTI, by Emory University, by WHO, and by Indian Institute, your attendance and your PDSA. Both are going on wonderfully well, but kindly keep it in the back of your mind. So with this, I would like to start the presentation of the day, and I would like to share my screen and invite 2 faculties right now, Dr. Manoj Jain and Dr. Mohan Kohli. Is my screen visible to you?
Yes, very much so.
So Dr. Manoj and Dr. Mohan, my request to you. We have PDSAs lined up, and we have very excited DTOs lined up, and their counselors and their team leads are as much excited. So what I request from you is we look at the PDSAs, we look at their graphs, and we make observations, analysis. We talk to the DTOs, we hear their mind, we pick their minds, and we move ahead. So with this, I hand over to you, sir, with the opening remarks, Dr. Manoj, and tell me when you want me to start the first PDSA.
Absolutely. So welcome everyone. You may be wondering, आप सोच रहे होंगे कि, what will and how will we be having our discussion today? And what we find in so many of these workshops and collaboratives that we do is that academic lecturing only goes so far. मैं आपसे lecture कर सकता हूँ, मैं आपको बता सकता हूँ, but what real learning happens is when one individual speaks and another individual who is a peer listens. So peer-to-peer learning is a phenomenal concept and it is incredibly effective. I would suggest even aap soche that you use that amongst your TBHVs and others. So today what we're going to do is peer-to-peer learning and not a lecture, but case studies, one after the other, real time as we bring one case after the other. So Dr. Mohan, let's not waste much time. Shall we have our first DTO presentation?
Absolutely.
From Dr. Ashmita?
And while the presentation is starting, just want to say one more thing. This is as much a learning exercise for us. We learn from every screen we see, every chart we see, every trend line gives us something new to discuss. And that is exactly what we are going to do today. This is not an evaluation of the PDSA. We are just going to see what the thought behind the PDSA is, what the data says, and how differently we can look at it. So, we're trying to see from different perspectives. That's about it for today, right, Manoj?
Absolutely. And we would ask folks to feel free to add their comments in chat. And then we'll work to try to invite them in, Commodore Raman as well. So let's begin with our first PDSA.
Thank you. Thank you, Dr. Manoj. I would like to invite Dr. Asmita Pathak, DTO Akola MC, Maharashtra, and to give the PDSA presentation. And you may also intervene and talk, but we may like to give the first 2 minutes to the DTO.
Absolutely. And if you may want to just make it a little bigger at 125 to 150%, that's perfect.
Will this be okay?
Yes.
I can make it bigger?
In fact,
yes.
I would say why 2 minutes? Actually, you can take 4-5 minutes.
Yeah.
That's the purpose. We want to listen and understand.
Sure. Great.
Yes, Dr. Asmita, over to you.
Yes, sir. Good evening to all of you, sir.
Good evening.
Representing from Akola Corporation, Maharashtra. CTTB officer, Dr. Asmita Pathak. Since 3-4 weeks, we attend these sessions, PDSA, boosting of TB notification. We learn more from it. Our city profile, 4,060 lakhs near about population mapped by CTD, and all TB program is handed over to me by 2016. Since 7 years, I look at this program. Our problem is that low performance in public notification. Our aim statement is that it is boosting up to 5% increase in public TB notification. Then we started it by process measure, and our time is near about 2 months. Process measure started that like this process map, patient come in our OPD. We have 10 OPDs in our city, medical college including. Then symptomatic patients like our declared symptoms, but physical examination done, sputum sample taken. We have 4 DMC with Akola Corporation, and we have well settled transport sputum mechanism in our city by private sector, and 4 X-ray facilities we have mapped by private sector. We have only one public X-ray facility Then this flow chart, patient come, then screen, then X-ray or and CBNet. Then patient comes through ISA activities. Is percentage is very low, but ASHA referral now it is improved by process. We do ASHA sensitization. Akola Corporation have 169 ASHAs, 10 UPSCs, and other facility medical college and private Ayurveda medical college. Through this PDSA, we sensitize more than 29 ASHA in these 2 weeks. We started our process measure by 8th of June, and then we started ASHA sensitization. 30 ASHA total sensitized, and 4 medical officers were sensitized. We got a very good, excellent result by this PDSA. We improve our public notification by more than 5%. Baseline data we have to use. We used 15th of March and 31st of April, up to 31st of April. Then we improve our notification by 5%. Sir, this chart you see at more than 85% cases up to April. 85 cases up to April, and then we start our process measures intervention during 8th of June. Then we improve it by 95, more than 5% we have achieved through the PDSA. And our silent blocks are 2, Krishi Nagar and Hariyarpet. We more sensitize those ASHAs by 2-3 weeks, and we got result from both Hariyarpet and Krishi Nagar side. We improvement seen in this during the PDSA, and we also we are trying for a best more than 5% up to 15% of notification. We can achieve it. We have confidence by this PDSA that we can achieve it more than 10% or up to 15%. We are trying for that. And during pandemic, we have low notification in 19 up to January 21. Low notification we have achieved, but now OPD is OPD are
Okay, great.
Excellent. Dr. Asmita, first of all, I should tell you that you have already increased your notification by 11.76%.
Yes,
You are just approximately 3% away from your target of 15%. And this has been achieved in 1 month, so to say. So now I would like to invite Dr. Jain and Dr. Mohan. Please do the analysis and give your comments and discuss it further.
Great presentation. And so, Dr. Mohan, what are your thoughts on the process and the outcomes that you're seeing?
See, one thing I would say, the process clearly, as she had clearly pointed out, one of the 3 reasons she said through the IC, many only a few patients come, but through ASHA sensitization and referral, maximum patients come.
Yes.
So they identified where they can make the maximum impact, right? So and they understood there are very few private sector in Akola MC. So that's what she said, and makes sense doing it in public sector and using the ASHAs. I just need to add, one more point, Manoj, what we can do over here is, if you see, if you can go to the aims and measures, you will see two measures have been given. Sensitization of the ASHAs for referral and sensitization of the MOs. But they are doing other activities also. Dr. Asmita, I understand you would also be doing monitoring of these referrals, the STS, the TBHVs, you would be monitoring also on a regular basis, I suppose, right? So because what happens is, if we need to take these monitoring measures also as part of the process, that keeps us busy, that keeps us alert, right, on the target. But that's a good point. And what's one more important point, Manoj? They had the baseline data ready. They had 169 ASHAs, but focused on two blocks, two TUs first, where there were silent TUs. Did you hear that point? Very important.
I love that word. Dr. Smita, you put it so nicely. And, it took me a second to absorb what you were saying, but you were very in tuned to the issue that, look, I have 15, I have 20 TUs. And in that, there are these TUs where things are not happening. So that is a low hanging fruit. You can do PDSAs in several ways. But if you can do the entire district, or you can do individual TUs or areas that you want to target. The reason you want to target in a particular area is because they are, what you said, silent. For some reason, they are not moving ahead. And what you found was that if you could get your TBHVs, you could get others to sensitize the ASHAs and the MOs, then the things would move. And likewise, you could see what is under your control, which is the process measure. You move the process measure and let the outcome measure be whatever it is, it will happen.
They will follow.
You have moved.
There will be a gap, Manoj. It is understood. You do some things and you wait for the results, right? Can we see the run chart? That will show always.
Yeah.
And
I think if we can unmute Dr. Asmita, and I think she wants to add more comments, but wonderful presentation. And this is the objective. This is what we're looking for each of the DTOs, to have this process in mind as you're doing it. So Dr. Asmita, if you can unmute and also share more, we would love to have you.
If you can see the monthly data sheet, so we can see how it is, the monthly data.
Yes, please, Dr. Asmita, you were saying.
Yes.
Yes, sir, we have monthly data.
Yes.
Ma'am,
so
you have done a beautiful work of this, and we can see that you have clearly identified your gaps. You have identified the geographical area where you want to work. Maybe one of the suggestions for future PDSA, I think we can incorporate monitoring measures also as part of the process measures, because you are doing those things regularly, right? So we can incorporate that, and you can expect the better results to show coming up in probably another 2 weeks time, right, Manoj?
Absolutely. 2 to 4 weeks, you're going to see that outcome measures go up. And let's just go up to see the graph again, Commodore Raman. Yeah.
Yes.
So now what Dr. Asmita, what we're seeing is your baseline. If you look at 2019 in your district, each month you were getting between 150 to 200 cases every month. You see that at their baseline. You still have not reached that. You're still hovering right now around 150. So we know that there are missing cases. We know that there are missing cases that are out there. Once you begin to find those missing cases using the boosting with the PDSA, then you will see that change. Just as after the pandemic, you saw the huge rise from boosting, from baseline, you will begin to see that rise to 200 and above 200. And that's what I would say. Now think, you've unit-wise, your TU-wise, you've thought. Now think, now also district-wise. You can just now take this cycle replicated in another TU, replicated in another area, and at a later time, replicated for maybe DBT or something else that has to be done. You have learned the whole process of using the PDSA to make an effective change.
Manoj, Manoj, I would also like to add one more thing. If you look at the three curves, right, we are coming back to the baseline overall, but
Yes.
it is primarily led by the private sector notification, not the public sector. If you see, it is still lagging behind. The blue line is still lagging behind. So there's a lot of scope for growth in the blue line, and the best outcome is achieved at the poorest performing areas, which you already have identified. That's a good start.
Yeah, so that's an important point, Dr. Ashmita. What Dr. Mohan has said, that look, something is different. Your private sector has reached higher, but your public sector has yet to achieve that same baseline. So there's a reason that could be, we don't know. Maybe those TBHVs, maybe those ASHA workers have been doing some other work. Now we need to deploy them here. Your thoughts and comments, and then we'll go to the next PDSA. Ma'am, go ahead. You can.
सर, आशा वर्कर जो हमारे हैं अभी तक के, उनसे हमको रेफरल बिल्कुल ही कम था, 10% से भी कम था करके ये पब्लिक सेक्टर का जो नोटिफिकेशन है ये डाउन होता चला गया। और ड्यूरिंग पैंडेमिक आशा वर्कर को काफी लोड था कॉन्टैक्ट ट्रेसिंग वगैरह का, और बाद में हमारा वैक्सीनेशन जो चालू हुआ कोविड का, तो उसके लिए भी हमने आशा का, जैसे कॉलिंग के लिए वगैरह आशा का ज्यादा हमने वहाँ पे उनका यूटिलाइजेशन हुआ है आशा का करके। ये जो अपना प्रोग्राम है इधर थोड़ा सा उनका यानी ध्यान रहा नहीं, तो अभी हमने सेंसिटाइजेशन चालू करने के बाद में थोड़ा इम्प्रूव हुआ है सर अभी, और हमारा 10 से 15 तक के और इम्प्रूव हो जाएगा कॉन्फिडेंटली। आई एम सेइंग दिस।
एक्सीलेंट, एक्सीलेंट। और सबसे अच्छी बात है कि आपने ग्राफ्स, आपके सिचुएशन देखकर, आपकी प्रोसेस मैप देखकर आपने आइडेंटिफाई कर दिया कहाँ पे प्रॉब्लम है, फिर आपने उस प्रॉब्लम को टारगेट करा क्वांटिटेटिव मेजर से, और आप वो प्रॉब्लम का सॉल्यूशन भी देख रहे हैं आपके सामने ग्राफ से, और आपके कलेक्टर को आप ये बता सकते हैं, you show them that look, we did this process and we did it in a systematic way, और हम इसको replicate करेंगे. That this is how change happens, and you will notice that within 3-4 months it will become a normal. You will become to use this process. So excellent, very good discussion.
Thank you so much.
Thank you.
Yes. And Manoj, one more thing, which is by the time the other one is opening, just one point I want to say. After doing this activity, learnings from this cycle, whatever we are discussing now, can be incorporated in the next cycle or the next PDSA. That's the beauty of a PDSA. It keeps on improving on itself. Yes.
Each time you do one cycle, you will learn what is working, what is not. And then you build on the next cycle. And the cycles are short. ऐसा नहीं कि 3-3 साल की cycles हैं. These are just short हैं. That's why 2-3 महीने की, 3 महीने की cycles हैं. In that time period, you have a lot of learnings, and do not think that this is work that is added on. जो आप काम कर रहे हैं वो ही काम ये है. Just think of that. आपको करना है notification anyways, पर आप efficiently नहीं कर पा रहे थे पहले. Now systematically or efficiently कर सकते हैं. That is the beauty, that you bring efficiency and effectiveness to it. So let us hear from Dr. Yogendra Sharma.
Good evening, sir.
Sir, आप म्यूट पे हैं?
Good morning. No, it's good. Now we can hear him.
Yeah. Thank you so much. I invite Dr. Yogendra Sharma. Ekta, whenever you are ready, start sharing the presentation. Or for everybody else, Dr. Yogendra Sharma has been with us as part of batch 1. It has been 1.5 years we are working together. Dr. Yogendra Sharma is working from a 100-year-old building, which has been given to him by the government, and he operates from there. His building, the situation in the building has been covered by many newspapers, but his resolve, nobody has been able to break. And that is what inspires us. He's part of BTN now. He's part of our faculty also. So I will not waste much time. I invite you, Dr. Yogendra.
Thank you, sir. Good evening, all of you. Sir, डिस्ट्रिक्ट अलवर राजस्थान जो है वो उसकी पॉपुलेशन 46 लाख के अराउंड है और हमारे पास 17 टीयूज हैं टीवी यूनिट। लेकिन हमारा जो नोटिफिकेशन है वो पिछले 3 साल में करीब 80 to 90% हम अचीव करते जा रहे हैं, लेकिन उसके बाद भी कहीं ना कहीं पेशेंट हमारे छूट रहे थे। जैसे पिछली बार हमसे डाटा मांगा गया कि आपका जो टोटल ट्रीटमेंट मेडिसिन जो सेल हुआ है उसके बीच में और इसके बीच में अंतर था, तो उसको हमने ये देखते हुए कि ये पेशेंट हमें छूट रहे हैं, तो अभी हमने जो PDSA था उसको नोटिफिकेशन को इम्प्रूव करने के लिए उसमें क्या हो रहा था कि जो प्राइवेट सेक्टर है वो पेशेंट्स को दवा लिख दिया उसने 10 दिन का कि 10 दिन बाद जब टर्न अप होके आएगा सेकंड फील्ड विजिट में उसको रजिस्टर करेंगे, तो वो पेशेंट हमसे छूट जाते थे। तो इसके लिए हमने तो हमारा प्रॉब्लम था कि नोटिफिकेशन छूट रहा है, लो नोटिफिकेशन है, उसके लिए हमने प्राइवेट नोटिफिकेशन को इंक्रीज करने का प्लान किया। 10% इसमें हमने प्लान बनाया और 2 महीने के अंदर इसमें हमने इम्प्रूवमेंट की संभावना तलाशी। तो इसके लिए हमने जो प्राइवेट प्रैक्टिशनर हमारे एंगेज नहीं थे उनको और जो फार्मासिस्ट थे उनको एंगेज करने के लिए प्लान किया हमने। तो इसके लिए जो भी पेशेंट अगर किसी के पास में मेडिसिन लेने के लिए जा रहा है और उसके जो प्रिस्क्रिप्शन स्लिप है उस पर अगर उसका निश्चय नंबर नहीं है, तो हमने उसको ये बोला कि या तो आप स्वयं से उसको रजिस्टर्ड करें फार्मेसिस्ट, या उसको वापस से उस प्राइवेट प्रैक्टिशनर के पास भेजें जिससे कि पेशेंट निश्चय पे रजिस्टर्ड हो और उसको सभी लाभ मिल सके और उसका प्रॉपर इन्वेस्टिगेशन और डायग्नोसिस हो सके, UDST हो सके, NPY हो सके। तो इस तरह से हमने इस प्लान को करने का सोचा, तो हमने कि एक भी पेशेंट जो है उससे छूटे नहीं। तो इसके लिए जो हमने प्लान बनाया कि सेंसिटाइज किया और फार्मासिस्ट को और नॉट एक्टिव पीपीज को। फार्मासिस्ट को सेंसिटाइज, अब अलवर में हम देखें तो 2500 से 3000 तक मेडिकल शॉप्स हैं, लेकिन जो प्राइवेट सेक्टर है वो पूरा का पूरा जनरली 80% तक शहर में है। तो हमने उसके लिए न्यूज़पेपर, और जैसे ही हमारे पास किसी का भी कोई भी प्रिस्क्रिप्शन गवर्नमेंट में लेकर के आता है, जैसे गवर्नमेंट में हमारा जो टीबी क्लिनिक है उसका OPD हमारा 100 to 150 पर डे है, तो कोई भी स्लिप विद ATT लिखा हुआ अगर हमारे पास विदाउट प्रिस्क्रिप्शन के आता है तो हम तुरंत उसका व्हाट्सएप उस PP के पास और उस फार्मासिस्ट के पास भेजते हैं या आपने इसको रजिस्टर्ड नहीं किया है। तो इससे हमें फायदा मिल रहा है और पेशेंट जो है वो बढ़ रहे हैं, और पेशेंट प्राइवेट सेक्टर का नोटिफिकेशन हमारा कंसिस्टेंटली इंक्रीज हो रहा है, लेकिन उसकी जो रेट है वो मैं समझता हूँ कि इन 2 महीनों में हम बढ़ा पाएंगे। इसके लिए मेरी टीम में हमारा PPM और STS और QIC जो है मैडम वो हमारा बहुत सहयोग कर रहे हैं। रन चार्ट देखेंगे। इनिशियली 87 हमारे जो एक्टिव पीपीज थे, और अभी हमने उस प्रोग्राम के दौरान जो हमारा बेसलाइन है वो मई 15 दिन का हमने लिया है। फार्मासिस्ट सेंसिटाइज किए हैं 23, 29, और अभी हमारे पास जो नोटिफाई करने वाले हो गए हैं 33 और ये 24। नॉक टेस्टिंग जो है वो धीरे धीरे अब हमें का पता लग रहा है, तो एक्टिवली पार्टिसिपेट करते हैं। और अब तक हम ये तो इसका जो डाटा है अभी 16 से 30 जून का पूरा नहीं हुआ है, तो हम जो अप्रैल में हमारा नोटिफिकेशन 841 था वो करीब 935 के आसपास हुआ है। तो इससे ये बढ़ना चाहिए, और हम जो उम्मीद करते हैं वो ये है कि कोई भी पेशेंट इसमें डुप्लीकेसी जो है वो भी हमें पकड़ में आ रही है और नोटिफिकेशन भी हमारा इसमें इंक्रीज हो रहा है।
Okay, can we see the run chart? The monthly data? Okay.
Great. And Dr. Yogen, before we go into discussing more of the अपन monthly data देखते हैं, उसके पहले मुझे आपकी एम स्टेटमेंट और टीम मेंबर्स देखना है.
Yes.
और हाँ, लेट अस वो डिस्कस करते हैं और फिर अपन रन चार्ट पे जाएंगे. तो आपने बहुत अच्छा आइडेंटिफाई कर दिया. आप देखिए फॉर द ग्रुप कॉन्ट्रास्ट, राइट. डॉक्टर अस्मिता ने बोला कि उनको सेंसिटाइजेशन करना है और उन्होंने चूज करा कि हमको आशा वर्कर्स एंड एमओस को करना है. डॉक्टर योगेन टुक अ डिफरेंट स्ट्रैटेजी. इनकी स्ट्रैटेजी अलग थी. इन्होंने बोला नहीं, मुझे फार्मासिस्ट को करना है और प्राइवेट प्रोवाइडर्स को करना है. क्यों? बिकॉज द प्रॉब्लम वाज द सेम, लो नोटिफिकेशन, बट जो आपके प्रोसेस मैप आपने जो बनाए उसमें आपको मालूम पड़ा कि अरे प्रॉब्लम आशा वर्कर्स में है, जो डॉक्टर स्मिता ने फाइंड करी जनरली, और डॉक्टर योगेन ने फाइंड करी कि प्रॉब्लम है फार्मासिस्ट में है या प्राइवेट प्रोवाइडर्स में है. ये बहुत अच्छी चीज है. सो यू हैव फिगर्ड दैट आउट एंड योर एक्सपीरियंस एंड आपने जो ब्रेनस्टॉर्मिंग करा इन दैट प्रोसेस मैप, Dr. Yogen, I assume that is how you came to that conclusion. Am I correct?
Yes, sir.
Okay. अब मैं आपको दूसरी recommendation करूँगा कि thought process is who is on your team. So if you look at, आपने DTO आप हैं, लव शर्मा जी हैं, महेंद्र जी हैं, STS.
Yes, sir.
हमने ये experience में देखा है, अब ये suggestion idea है कि आप जब टीम बना रहे हैं तो अगर पॉसिबल हो, अगर एक फार्मासिस्ट या एंड और एक प्राइवेट प्रोवाइडर. नाउ आई नो दैट वी थिंक ऑफ अ टीम दैट ओनली इज पार्ट ऑफ योर TU unit or part of your district TB office. But we find कि कई बार हम जब दूसरे प्रोवाइडर्स को इवन थोड़ी टाइम के लिए टीम मेंबर बना लें, उससे क्या होता है कि it changes the entire dynamics. अगर कोई भी प्राइवेट प्रोवाइडर बोलता रहा होगा कि अरे ये मेरे लिए काम नहीं है, तो आप उनसे बोल सकते हैं साहब ये काम है, डॉक्टर फिरोज हैं, he is on our team. And Dr. Firoz is a well-known private provider, and you bring them into the team and in the whole concept. तो मेरा कहने का मतलब learning lesson ये है यहाँ पे thought process कि अपनी जो आप बना रहे हैं, and this is for all the DTOs, when you build a team, even if you can for a little time, and you tell them we're not going to take up, we're not asking you to devote all your time, but make them part of the team, share information, get them on a Zoom call or an audio call for 15 minutes. Tell them that this is an initiative and we will give you due credit, part of the bigger picture. That is very effective. So this conversation, if building a team, so what I would consider doing in your next PDSA, you can have, if the same thing, having a pharmacist or having or a private provider. Dr. Mohan, your thoughts, and Dr. Yogen, your thoughts. Yeah.
Yes, I would definitely agree कि अगर हमारी टीम में उस तरफ से कोई होगा, उस तरफ से from across the table, उसका impact different होता है. Number one. एक चीज और मैं इस PDSA में बताना चाहूंगा आपको. अगर आप देखेंगे, थोड़ा सा ऊपर करेंगे इसको, ऊपर, yes, और ऊपर, yes. By how much you would want to change, यहाँ लिखा है 10%. अगर इसके सामने हम स्पेसिफाई कर दें from this person to this person, वो समझने में आसान हो जाएगा, because 10% के मतलब कुछ भी हो सकता है.
Yes, sir, yes.
आज अगर मैं 40% पे हूँ तो 10% 40 से 50 भी हो सकता है और 10% 40 से 44 भी हो सकता है. 10% of what? ठीक है. So ये अगर स्पेसिफाई for everybody, अगर ये स्पेसिफाई करें, जो देखने वाला है, पढ़ने वाला है, उसको क्लैरिटी मिलती है. Right, Manoj?
Absolutely. And these are, little details, but you have 95% of the things beautiful.
Absolutely.
Perfect. And what we are doing, सबके लिए conversation के लिए, कि अपन अब डेप्थ में जा रहे हैं, अपन देख रहे हैं कि क्या चीज आपको सक्सेस बियॉन्ड सक्सेस ले जा सकती है. So those are clarity that it brings clarity to a statement. आप जब कलेक्टर को दिखाएंगे कि मैंने 10% करा है इंक्रीज, तो वो उसको नहीं समझ में आएगा, अरे आप 40 to 50 जा रहे हैं या 40 to 44 जा रहे हैं. तो parentheses में आप लिख सकते हैं 40 to 50.
Can we see the monthly data?
हाँ, Dr. Yogen, आपकी comment on the team idea and
सर इसमें प्राइवेट प्रोवाइडर को तो जोड़ने का सर हमने कहा था, लेकिन क्या है कि प्राइवेट डॉक्टर से वो कहते हैं हमारा नाम नहीं देना, इसलिए बाकी तो वो सभी कॉन्टेक्ट में है सर.
ठीक है, तो हाँ उनका नाम नहीं देना है तो अपन नीचे लिख सकते हैं वन प्राइवेट प्रोवाइडर.
यस सर, बिल्कुल.
हाँ, उससे और आप सोचते हैं कि वैल्यू होगा अगर उनको इवन थोड़ी देर के लिए टीम में लाना, बातचीत करना, उनसे आइडियाज लेना.
मनोज,
यस सर,
ये वाला जो येलो लाइन दिख रही है, टोटल टीपी नोटिफिकेशन अप एंड डाउन अप एंड डाउन अप एंड डाउन, व्हाट डू यू अंडरस्टैंड बाय दिस? क्या डॉक्टर योगेंद्र, क्या आप
सर इसमें क्या होता है?
जी
सर इसमें क्या है कि अलवर में प्राइवेट सेक्टर काफी बड़ा है. तो उसमें कई हॉस्पिटल्स ऐसे हैं जो कि अपने पूरे डाटा को लेकर के कलेक्ट करते जाते हैं.
परफेक्ट.
और वो सर जाकर के फिर चढ़वाते हैं, तो एक ही दिन में वो डाटा शूट कर जाता है सर.
राइट.
बार बार उनको कई बार सेंसिटाइज कर दिया कि आप इसको बिल्कुल रियल टाइम एंट्री करिए, लेकिन सर वो धीरे धीरे सेंसिटाइज होंगे उससे. नो
प्रॉब्लम. तो डॉक्टर योगेन, आपने बिल्कुल सही इश्यू बताया है कि ये जो जैगडी लाइंस हो रही हैं, दिस इज एन आर्टिफैक्ट. ये आर्टिफैक्ट नॉट कि रियल ऐसा हो रहा है. आपके टीबी पेशेंट्स ऐसा नहीं कि एक महीने इतने आते हैं और दूसरे महीने कम आते हैं. ये आर्टिफैक्ट है ऑफ रिपोर्टिंग. So this is a concept that is really important. When we look at data, we need to understand what is the artifact of reporting and make sure that we understand the underlying cause. आपने बिल्कुल beautifully underlying cause बता दिया कि अरे ये तो data hospital से every month आ रहा है और cumulative करके आता है.
Can we go to the quarterly data sheet? Quarterly, you can just understand this variation become less. See this?
Yes, up here.
Because आपने accumulate कर दिया एक साथ.
Yes sir, yes sir.
Yeah, and you can ignore the this last one because अभी पूरा quarter नहीं हुआ है, पूरा data नहीं आया है, but आप ये देखिए that you are able to blend that in. And you can see the jaggediness is a lot less. Beautiful.
Yes, great. Thank you, Dr. Yogendra. आपके अगर कुछ last comments हो तो इससे पहले कि हम अगले उसमें जाएं, Dr. Yogendra.
सर इसमें क्या है कि अभी भी इतना बड़ा डिस्ट्रिक्ट है हमारा, तो लेकिन जो क्वेक्स प्रेस्क्राइब कर देते हैं ना, उसके कारण से सभी टीबी पेशेंट रियल टाइम में डायग्नोज नहीं हो पा रहे हैं. और उसके पीछे रीजन यही था कि फार्मासिस्ट को मैं बाउंड कर दूं. मैंने 2-3 बार पेपर में भी निकलवाया कि कोई भी मेडिसिन बिना निश्चय आईडी के नहीं दी जाएगी.
सर ये अच्छा काम किया आपने बहुत, एंड वी विश यू बेस्ट ऑफ लक फॉर दिस. और अगर आप ये करेंगे ऐसा और ये सक्सेसफुल हुआ तो आई वुड सजेस्ट इसको अच्छे से डॉक्यूमेंट करिए प्रोसीजर को, सो दैट बाकी डीटीओस भी इसका बेनिफिट उठा सके.
Thank you, sir. Thank you very much.
Thank you so much.
And one more thing, I think in that PDSA, well, that we'll get that. What was very interesting is that the lag between the process measure and the outcome measures, we were still not able to see in the outcome measures all the change that had been the process measures. So just to remember that आपके process measures immediately change हो जाएंगे, Dr. Yogen.
Yes, sir.
पर आपका जो outcome measure है उसको चेंज होने में 1-2 हफ्ते, 1-आध महीने लग सकते हैं. सो डोंट बी डिस्करेज्ड. आप ऐसा मत सोचिए कि मैं कर रहा हूँ, प्रोसेस चेंज हो रहा है पर आउटकम नहीं आ रहा है. इट जस्ट
Yes, sir.
Absolutely.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, Dr. Jogendra ji. Thank you so much. Thank you,
sir.
Dr. Manoj, Dr. Mohan. Is Dr. Kaushik Das there? I know I've been told you are here, sir. Can I hear your voice? I understand you are connecting from Assam. Assam is in bad weather right now. Yes, you are there. So handsome, so clear on the screen. Thank you, Dr. Kaushik. And I know, Akashdeep, I will talk about you as well, that you are conducting all the sessions in the vernacular language, and we really appreciate your support which is coming, because if you can talk in the language of the DTO or any other person, it makes a huge amount of difference. So
Okay.
I would like to present the PDSA.
Great. And team lead Devlina, excellent work in getting all of our counselors and DTOs to be involved, engaged, and helping through the whole process of building the PDSA. Great job.
So, Dr. Manoj, if you have a look at this PDSA, and may I request you to engage Dr. Das, in this discussion of his PDSA, and you will get wonderful inputs from him.
So here's the hello, Dr. Das.
Yes.
So
Yes, sir.
yes. So the beauty of all of this is that in a standardized one quick document, we're all able to just instantly see what you're doing. And we noticed that you find that the problem was low notification and
Yes.
the low referral rate to the OPD.
Yes, sir.
So now let me ask you quickly, how did you figure that out, that the problem was in the referral for OPD, low referrals?
Actually, sir, I am from district Kokrajhar, which is a difficult geographical area in Assam. And before COVID, we have achieved more than target. And after COVID, during COVID, my notification is low down. But after joining the course from the PDS, I have identified only one point, is the low sputum referral.
Yes.
Is due to low sputum referral from the peripheral PHA,
Yes.
public health institution. After that, from the 9 June, we have started the intervention.
Yes.
And mainly, I think CHOs will be the game changers of this program now. So based on that, I have physically trained 12 numbers of MOs and 44 number of CHOs.
Excellent.
On 18th. And sir, one thing, one of my CHO has initiated the TB treatment from HWC, first time in India, I think. First time in Assam also, and first time in India. So CHOs are well trained and results are coming, and they are referring the patients sputum referral through Nikshoy ID.
Yes.
So I think the cases of notification will be increased in my district by 5% during 1 month.
Yes. And so your aim statement was that in the district of Coach Rajkar, that you will increase, so you would increase notification by 5%.
Yes.
And you have a time frame, and your interventions are well put together in the sensitizing the right target audience, and you have also have your team together, and and if possible, add again same idea, if one CHO could be potentially a member of your team, it adds great diversity and thought process also.
Yes, sir. So I have given target to each CHO 10 sputum sample per week. That is more important.
Great. So, and then we can see your process map. You know where and right there in that when to do the sensitization and who does it. And you can see that intervention at that stage. So the beauty of our conversation is some people realize sensitization has to be done at the pharmacist. Some people realize the sensitization at ASHA. Your work says, hey, CHO need to sensitize. And so, and we look at the run chart, and what we are seeing is that you're just beginning your interventions Your CHO sensitization has begun, and soon enough you will see the outcome measures of that as well.
Yes.
And you can see that impact. Kya sabse अच्छी बात ये है, the beauty of this, Dr. Das, is कि आपको जो CHOs है and दूसरों को, those people, individuals, you don't have to keep speaking to them in a ki, do this. If you just show them the data that we have done this, and you show them the graph that this is your activity that has done in beauty, that will make all the difference in the world.
Yes.
Great. Dr. Mohan, your thoughts?
Sir, I'll just say one thing. If Dr. Kaushik,
Yes.
please correct me.
Yes.
Your district does not have an active private sector. Please correct me if I'm wrong.
Yes, sir. I have only two, sir, private sectors. One is private practitioner, one is nursing home. Two
Why I
persons
can
are
say that, sir? Why I can say that the data is telling me. I am not.
Yes.
I don't know about your district.
Yes, sir.
One
Yes, sir.
slide
You are
is telling
correct.
me because the red line is almost at 0.
Yes, sir.
which
Yes, sir. You are
shows-
correct.
Which shows your intervention
Yes.
primarily will be public sector oriented, and anything
Yeah.
which leads to a problem in the public sector delivery will lead to an
Yes.
impact in your system. So you need to have a good risk analysis
sir.
plan for your public sector services,
Yes, yes, yes,
because
sir.
you don't have a private sector to bank upon. See,
Okay.
Manoj, just a
Yes.
simple thing, and you know about the district, right?
Yes, and Dr. Das, it's almost as if Dr. Mohan has been walking through your district, and he can, with the data here, he can tell you कि आपके पास private sector में there is not many patients coming there at all. Now,
Yes.
now the question is, you must have exhausted this, you must have looked at this, that are there any private sector doctors or not? And you found that no, there is obviously not. And your target is obviously appropriate, that you work on the public sector and use that. Now, let us talk about what happened with the pandemic, with the recovery, and now where to take that next. So if you look at your baseline, you were again between close to about 150, 200 per day.
Yes.
You have yet to be able to achieve per month, sorry, per month, excuse me. But with now you're still recovering at only at about 150.
Yes.
So there is still a lot of room for boosting in your
Yes.
district. What do you
Yes.
think?
So I can boost, sir. From June 15, if you see, in 1st January to 23rd June, in 21 and 22, comparing to this,
Yes.
I have now more than 150 cases I have gained in June.
Can we see that chart? It will be in the
Yes.
run chart.
Yes.
If you hit the run chart, Commodore Raman, and or I think, yeah.
Yes. So if you can see from January, we can see the difference which is coming.
Yeah. So outcomes will be there. You can see,
44.
and yeah. So we'll begin to see the outcomes come very soon, and the interventions have already been there at 44 and 12 interventions. Excellent. Right. So Dr. Das, a great work. You can see the relationship of the process and outcome.
Yes.
The beauty also is use this to convince your seniors, your colleagues,
Yes.
कि जो काम कर रहे हैं, what they are doing is making an impact, because that is what people want to see, that whatever they're doing is making an impact. And let the graph do the talking. And as Dr. Mohan easily read through your graph, the private sector isn't there. Others will read, oh my goodness, we saw the boosting and the impact of that.
So thank you, Dr. Kaushik. Thank you so much.
Thank you.
And from Assam, we take you to Ladakh. And we have Dr. Iqbal Ahmed, DTO Ladakh, who has joined with us. I just want you to appreciate this, DTOs. We started from Maharashtra, we went to Rajasthan, we went to Assam, from west to east, and from east to the ultimate north in our country. So Dr. Iqbal Ahmed is there, and Shubhangi, would you be in a position to present the PDSA? You may start doing so. I'll stop sharing. And Aneri, you've done a good job. I'm sure you can see your own photograph.
Till the time this is coming up, I would just like to add, डेटा सब बताता है. सर आप बोलते हो ना, सब झूठ बोलता है लेकिन डेटा से ही बताएगा, सब कुछ खोल देगा, राइट? सो डेटा देखिए, आपके पास इतना डेटा है निक्षय से. इट्स अ ब्यूटीफुल ऐप, इट्स अ ब्यूटीफुल पोर्टल. सब दिखाता है आपको, सब बताएगा मुझे कहाँ काम करना है, राइट? You just need to spend time on looking at the data. Thanks.
Absolutely. Yes. So over to you, Dr. Manoj.
Yes. So, Dr. Ahmed, let us hear Aapki, what is your PDSA cycle, and Aneri and Shubhangi. Thank you so much. Great. So working with Dr. Ahmed. So, Dr. Ahmed. Yes, can you go ahead, sir.
Yeah, sir, as Sir Ladakh is geographically difficult and inhospitable terrain, with a total area of 58,000 square kilometers, sir. And the population of Leh is around 1,14,000, and we get around 150 patients are reported every year. Sir, let me tell you, sir, I joined as DTO on 2nd of April this year, just almost 2.5 months before.
Excellent.
So,
okay.
so sir, after going through the first quarter of data, which were not encouraging, like the total notification was 31, and the referrals were less than 1% in almost all blocks. So on 6th of April, just after 4 days, I conducted a virtual training or virtual meeting with all those medical officers and CHOs who with internet facilities, sir. Sir, the Director Health Service was also attending it because he was holding additional charge of STO, and the Chief Medical Officer and all BMOs were attending that virtual VC, sir. So, 4 thing, 4 चीजों पे हमने सर स्ट्रेस डाला, 4 चीजों पे. एक ये है कि रेफरल जो है, रेफरल्स फॉर स्पूटम एग्जामिनेशन टू बी इंक्रीज्ड फॉर मोर देन 2% ऑफ द ओपीडीज. ये हमारा एक सबसे बड़ा ये पॉइंट था. उसके बाद देन कैरी आउट एक्टिव केस फाइंडिंग्स. उसके बाद इम्प्लीमेंटेशन ऑफ टीपीटी टू ऑल कॉन्टैक्ट्स. एक्चुअली इकरा जो है अभी रिसेंटली हमने पिछले 1 महीने से यहाँ पे, पहले इकरा नहीं होता था, अब हम इकरा भी हमने स्टार्ट किया है. इट्स फ्री ऑफ कॉस्ट टू द पेशेंट्स. उसके बाद द role and responsibility of all CHOs in context of NTEP, because sir, 80% of the CHOs were recently appointed, so they had no idea about NTEP. तो ये 4 चीजें जो हमने स्टार्ट में जो हमने ये फर्स्ट वीक में हमने किया था, सर. सर मैं आपको ये बता दूं कि फर्स्ट क्वार्टर में जो स्प्यूटम थे, इट वाज 735 स्प्यूटम्स हुए थे जनवरी, फरवरी, मार्च में. तो लेकिन अभी तक उसके बाद अप्रैल में और अप टू 21 जून द स्प्यूटम जो है वो 1872 जो है इंक्रीज हुआ था, सर. और उसके बाद अगर आप नोटिफिकेशन देखेंगे, फर्स्ट क्वार्टर में 31 था, सर. अभी ये 82 पे हुआ है, बोथ प्राइवेट और पब्लिक सेक्टर. लेकिन हमारे यहाँ ले में भी सर जो प्राइवेट सेक्टर है वो बहुत ही कमजोर है. आई मीन जस्ट हमारा जो टारगेट है वो 5 आउट ऑफ 175 जो हमारा एक टारगेट होता है, उसमें 5 जो है प्राइवेट सेक्टर के लिए, सारा हमारा पब्लिक सेक्टर पे ही फोकस है, सर. उसके बाद सर वर्चुअल ट्रेनिंग के साथ साथ आई फाउंड लिटिल लेस इफेक्टिव जो वर्चुअल ट्रेनिंग जनरली होता है, तो फिजिकली अब हमने ट्रेनिंग स्टार्ट करना शुरू किया. तो देयर आर 5 ब्लॉक्स इन आवर ले डिस्ट्रिक्ट, 5 टोटल 5 है, सर. 5 में से एक ब्लॉक, सर, इफ यू हैव हर्ड ऑफ नुब्रा, So Nubra block है sir, वहाँ पे it took me 3 days, वहाँ पे 3 दिन बैठे रहे हम, और उसके बाद हमारी टीम और मैं था, उसके बाद वहाँ पे फिर हमने वहाँ पे CHOs और मेडिकल ऑफिसर्स, जितने भी CHOs थे और जितने थे, उनको ट्रेनिंग दिया सर नुब्रा में। उसके बाद we have total 87 CHOs in our Leh district. Out of 87, 55 are trained so far, sensitized so far. इसी तरह से अगर आप मेडिकल ऑफिसर्स, पीडियाट्रिशियंस एंड डेंटल सर्जन्स अगर आप देखेंगे, 30 को सेंसिटाइज किया है. इट शोज ओनली 13, बट 30 ऑफ देम आर सेंसिटाइज सो फार. दो ब्लॉक्स में, ये 2 ब्लॉक्स में हुआ है, एक ले ब्लॉक, एक नुब्रा ब्लॉक एंड खालसे ब्लॉक. ले ब्लॉक के में हमने अभी CHO सारे CHOs को ही सेंसिटाइज किया है, मेडिकल ऑफिसर्स को नहीं किया. उसके अलावा BMOs को अलग फिजिकली सेंसिटाइज हुआ है सर. तो इट्स इन, अभी ये प्रोसेस में है सर.
Abhishek, can you show the process? Can you show the run chart, Abhishek? Run chart. Yes. Okay.
So your process measures are in place, and then we should see the outcome measures within the next 2 to 4 weeks, the impact of those processes. Just sensitization aap kar rahe hain, that will have an impact over there. So several things I really like about this is you've taken 2 of the ideas that we have talked earlier, like pharmacists engaging and CHOs also. Then you said, look, we'll also go block by block as well. Then you've incorporated that concept as well, which is good, and focusing on our idea of getting the sputum as well. I think all very good approaches. The sensitization is really important as well. So you're in the right area. Here's another thought and idea. Your population is not as large as other areas, but it may be more vast. And that puts a new dimension of how to approach these things. Or aapne uska solution find kara, which is that you said, let's go virtual, right? You said that let us go virtual and try to bring these people virtually. So what I'm saying is that each district in the country, apni country itni vast hai, each district has different issues. You as DTOs have to see what will work well with your district, learning, listening, and hearing and reading about what others have done to be successful. And where you find that yes, virtual worked for a certain level, but then in person was necessary too. These are all learning lessons that you do with that focused end goal. Apna focused end goal hai, look, we have to increase that notification and increase it by doing those process things. If I do those process things, it will ultimately improve that. So I think that's great. I think we have some photos, and then let's look at the monthly data as well.
Can we see? Yeah.
Yeah.
Can we see the monthly data, month-wise data?
Abhishek, just show again, please.
Abhishek? Yeah.
Yeah, if you go.
Yeah. Good.
Yes. Okay.
Wow.
So this is very interesting, Dr. Iqbal. Now, so we look at this. So this is what when I look at this, I'm going to say a couple of things. One, the private sector is not very prominent in your area.
Yes, sir.
And so maybe they don't exist like we had discussed earlier. But something happened in December
2021. December 21.
So this is
they were active case findings, sir.
Okay.
Whole case findings
was there. Good. So this
Yes.
is again, Manoj, just by looking at that, some event happened or something happened. So just by looking at one trend, you can get to know so many things.
Perfect. So अगर आप जैसे senior level को कभी, if you show this graph, what you do is you show the graph and you annotate it. जैसे baseline pandemic recovery annotate कर दिया अपन ने, you annotate and put an arrow and you say, look, active case finding did this. Dr. Iqbal, what this tells me is that there are many missed cases out there. If you are able to find close to 50 in a month, 50, 60, when you're doing active case finding, imagine if instead of doing once in 2 years or once in 3 years active case finding, you did it every 3 to 6 months. You will then see, you'll see those cases, you'll find them and they'll go down. So a very important point for all our DTOs to keep in mind, that active case finding interventions will lead to a change in your data. That data then tells you that, listen, there is a lot that's out there. I still haven't picked it up. And then you work to pick it up. And each time that line will come lower. Why? Because you stop the transmission. You stop transmission. So
peaks will become smaller. You will get peaks, but smaller and smaller mountains.
Okay, great. Any questions, Dr. Iqbal?
No, sir. Thank you, sir.
Was that helpful? Was that helpful to understand with analysis?
Yes, yes, definitely, sir. These BTN campaign was really helpful for me, sir. I have joined just 2 months back, so these were really helpful. Guided me a lot, sir. Yes.
Great, pleasure to do it. So, Commodore Raman, I know that we have many others to discuss as well, and we will continue discussing. And
what we can do is we might not go into the details of each and every point. You can understand what the main interventions are, and maybe look at the data and see what it tells us, right?
Sure, absolutely.
So great learnings. I am frankly enjoying it thoroughly because such wonderful analysis is coming up, and absolutely learning is happening because har data kuch kehta hai. So with this, now we take you to Jharkhand, and I invite.
And I would also request people to ask questions in case they have any.
Absolutely. DTOs, these sessions are for you. You are the focus. You are the center. You are the cause. So if there is anything which is in your mind, please share it. And you are the priority. Absolutely. There is no doubt about it. So with this, I would like to invite Dr. S.N. Chaudhary and Devlina. Please start sharing your screen whenever you're ready. So DTO Lohadaga, please go ahead, sir, with your PDSA presentation.
Good evening, sir. I am Dr. S.N. Chaudhary. Actually, basically, I am a surgeon. And previously, I was working at this place as Deputy Superintendent. I just joined on 16th of April this year. And I was also taking care of District COVID Nodal Officer and Sir,
go ahead.
We have five TU in this. This is a very small, rather this is the smallest district of Jharkhand, but it is not. It is, of course, it is very small, but it is difficult to manage because more than half of the area is very difficult terrain, and it is a tribal district. The main problem was, as it has been discussed by many others of my DTOs, the main problem was just poor notification. We are having a baseline of 75%, sir. We have a population of roughly around 5,60,000. We are having a lot of Sahiyas also, but actually I must tell you that Sahiya at our place, because it is a difficult terrain, so those who are actually in the hilly areas, they are either working hard, but they are not percolating to us, or they are not seen by the people, so they are not referring. And by some way or the other, they were actually not coming to our stream, just maybe due to their engagement in some other works. तो हम लोग के यहाँ अभी तो टोटल सहिया सर तो 506 है, but recently हम लोग का 455 we are working with the Sahiyas. So we had a plan our plan is, since we have a baseline notification of 75%, so we are just hoping to increase it in 1.5 months by 5%, sir. Starting from 20th of this month, and it will cruise through whole 1.5 months, and it will end up to 28th of July. And our main जो हम लोगों का PDSA का जो हम लोगों का टूल हम लोगों ने इसलिए किया है, our plan is to sensitize our सहियाज. Actually सहियाज जो हमारे यहाँ परफॉर्म कर रहे हैं सर, उसमें कुछ सहियाज तो परफॉर्म कर रही हैं ऑलरेडी, उनको हम लोगों को जस्ट एक सेंसिटाइजेशन करना है. लेकिन कुछ ऐसी हैं जो कुछ गांव को कैडर करती हैं जहां पर अभी तक कोई नोटिफिकेशन हुआ नहीं. सो दोज आर द एरिया विच वी आर मिसिंग. तो हम लोगों ने उसके लिए प्लान किया है. एक्चुअली हम लोग फर्स्ट हम लोगों ने 37 लोगों को ट्रेन भी किया उसमें, जिसमें कि हम लोग बेसिकली वी हैव ट्रेन्ड them as a master trainer, and our first training module was focused on Sahiya Sathi, BTT, STT, and other senior Sahiyas who are really very active. तो हम लोग उनको मास्टर ट्रेनर बनाएंगे, एंड दे विल गो टू देयर एरियाज, और वो लोग वहाँ पर क्लस्टर्स में ट्रेनिंग देंगी. और हमें जो हमारा जो टीम है, उस टीम में हमारे मैं हूँ, STS हैं, STLS हैं. अगेन आई विल जस्ट टेल यू दैट वी हैव स्ट्रेन in this of our this thing. Our STS and STLS are very less. We are just one each. So we are having lab technician and many others, which we have already trained them how to do that, and they are handling our Nishchay ID and everything. So we have just made them acquainted with every program, and they will take care of the level of the sensitization which has been done. The second thing which we are planning for is the training for the medical officers. Actually, medical officers, they are not lot many medical officers here, but I must tell that half of the medical officers, they think that working at the district hospital or at the periphery, actually, since they have a lot of other works, and those are of primary concern for them. So actually, this is a high time that we should motivate them that actually tuberculosis, being a flagship program of our Prime Minister, and we are destined to have this TB-free India by 2025. So we don't have less time. So we will have a training sort of. Actually, they are already trained, but they will have a training. Tomorrow we are planning for a training of 27 doctors, and we will train them. Then we'll have a system of pushing messages we will be putting on their WhatsApp. Actually, we have got a WhatsApp group also. So we'll push message, and we'll ask the person who is pushing the message. Actually, 1 or 2 person we have just destined for this thing to push the message, and they will see how many of them are seeing the message, and they will inform me or to some other persons, and we will phone individually. So I think
okay, so that's great. Excellent, Dr. Chaudhary. So several things I'm getting aapke presentation se, that first, that clearly identified the problem and the intervention. You've taken many process measures in hand, ASHA workers, and then you added a new element, the train the trainers, master trainer program you've implemented, and then also the MO's training as well. So you are throwing what we say the kitchen sink at this problem, which is okay, which is good. It is just that you have to be able to juggle all of those process measures to see and make sure that we're able to do that. And so your team is superb, that you're very much able to do it. It's just making sure that you can handle that many number of interventions all at once. Sometimes what people do is they do focus on the ASHA workers initially at first cycle, then they may focus on the MOs at another cycle, but it really depends on the capacity of the district. So I think that is very good. Dr. Mohan, your thoughts, and then we can look
Manoj,
at the monthly data.
Adding on to your point, why it was possible in this district, because it is the smallest district in Jharkhand, and the physical travel would be lower and all those, so possibly control factor comes in, right? So that's probably one thing which, and if you can look at the monthly data, there is something. Okay, here you can find, I don't know why we have one peak of the peak in the private notification, whereas the public notification was still going down that month. So probably, I don't know, we can't say it's an active case finding. Over here we cannot. If you look at in October 2020, just one point, Manoj, we should always look at the odd man out, something which stands out.
Sure,
right?
absolutely.
So can Dr. Chaudhary, do you have any idea why private notification suddenly jumped in middle of 2020, middle of the pandemic, active phase of pandemic?
Mohan sir, actually, I was yet to join at that period, but
okay,
I can just make it out that maybe that some of the private partners, they might have entered into our notification process.
So,
maybe.
Exactly. So let me take a moment and say the reason is not as important. The real reason, the real thing is that we question every piece of data, every peak and rise. So that is very good. This is great that that we are looking at the data in a good way, in a unique way. But it's important to see how that data plays out in our thinking and questioning. Yes.
We should look at this data like we look at the stock market data. We follow it eagerly. It is going up, it is going down, it is making me money, I am losing money. So look at this data as important as a stock market data.
And lots of times, I'll be honest, I don't have an explanation. Something has happened and I cannot predict of that. But the very fact that I make an inquiry, sometimes in my team, the TBHVs or others are able to come up. Excellent, Dr. Excellent, Dr. Chaudhary. Thank you so much. And also to our counselors, Shushim, and our team lead, Devlina.
Sir, I would just like to just tell you something, sir. Actually, you rightly said that I have taken so many things together as a thing, but I would say that they are all interrelated, sir, because if Sahiyas are putting their effort to make the notification more, my doctors, if they are dormant and they are not taking care of all those patients coming to our system, so that might impede our this thing.
Yes. You're absolutely right.
Those two.
Yep, that makes perfect sense. Yep, you're exactly right. And in your case, I would have done the same thing, because you know that in your district to make that change, that would be necessary. Great, Commodore Raman, excellent conversation. If we go to our next district.
Thank you, Dr. Chaudhary. Thank you so much. And now we go to District Pakur. Dr. Etha Shamuddin, and the best part is that the PDSA, as the presentation will happen, will also get populated, because the TTU had been busy. He has been working. He has the data, but at the same time, I'll request Ankita, जब DTO present कर रहे हो, तो आप data fill भी करते जाइएगा, because data है DTO के पास. So, Dr. Saab, please present your PDSA. बहुत स्वागत है आपका.
Yes, go ahead.
Good evening, all. So I am Dr. Etha Shamuddin, DTO of Pakur District, Jharkhand, India. So there is no any challenges for notification, because Pakur District have done very well in every year in notification mainly. what target have given by government of India or state government, Pakur have more notification and target. First thing I want to tell you, in present year, Jan to June till date, Pakur district have notification 113%, 13%, where in private sector 162%, in government sector means public sector 106%. We have achieved good notification because of hard work of our Sahiya, Asha worker, male health worker, MPW, and CHOs and medical officers. Mainly we have acquired 4 things to increase the notification. One thing is identification of patient beneficiary. Second, after identification, investigation. And after investigation, as soon as possible, start the treatment and then follow up. Because of 4 good things, we got a good notifications. Then what the challenging actually challenging is, it is the tribal area and population is a scale. So problem is transportation of a sputum from village to CSC or TB unit, TU unit, and nothing else. So any advice anyone want to give me, so please give me advice, or anything I want should to change, so please tell me about the changes. Thank you.
Okay, great. So Dr. Etesham, you have identified the problem, and now you have sort of looked at what are the potential solutions. For Aapka district unique hai, that you have much more tribal areas, and how does one do that? And you're targeting the Ashas as well, which is really good. And that shows us that that is where you think it's going to work. And then you added this another element of home visits. You have found that that will be a new, or not, maybe not new, but an approach that will be more effective. So Dr. Mohan, as we hear Dr. Etesham and his challenges, he can increase notification, but in tribal areas where he is at, should he be thinking of different strategies, different approaches? Because there's very much of a different migration population there. How does one target those ideas?
Manoj, I would say where there is problem, there is always an opportunity right next door. I'll tell you, in the tribal districts all over India, we have the tribal welfare ministry, who are also running their healthcare facilities and have various other programs and opportunities and schemes available. Probably just by exploring that, I don't know whether you have explored that to the fullest extent yet. आपने पूरा ट्राइबल वेलफेयर की जो पॉलिसीज हैं, जो हेल्प है, अगर उसमें टैप इन करेंगे तो हम जो ट्रांसपोर्ट वाला मैकेनिज्म और जो स्पूटम का वो हम ट्रैवल डिस्टेंस कम कर सकते हैं, उस चीज को देख के अगर हम कोशिश करें तो डॉक्टर एहतशाम, मैं यही सजेस्ट करूंगा, अगर हमने पूरा नहीं उसको एक्सपीरियंस किया अभी, तो एक्सप्लोर करना बहुत जरूरी है. प्लीज आप बोलना चाह रहे हैं डॉक्टर साहब?
हमारे यहाँ सर स्पूटम ट्रांसपोर्टेशन का जो वो बहुत माइल्ड प्रॉब्लम है, वो भी बहुत इजी वे में सॉल्व हो जाएगा. कैसे? ऐसे कि हमें स्पूटम ट्रांसपोर्टेशन के लिए पर किलोमीटर सरकार ने कुछ रेट फिक्स किया है, जिसको इंसेंटिव कहते हैं. ये टीवी एक अलग डिपार्टमेंट होने के बावजूद भी एक अकाउंट जो है वो अंडर डिस्ट्रिक्ट अकाउंट मैनेजर के, वो पैसा रिलीज नहीं करते. अगर किन्हीं को 9 मंथ से अगर इंसेंटिव नहीं मिलेगा तो क्या वो सही टाइम से वर्क कर पाएंगे?
जी,
टोटली अग्रीड. सो अब आपकी
एक चीज और बोलना चाह रहा हूँ, 1 मिनट सर, और प्लीज
बताइए.
यहाँ तक के जो हमारी एक्टिव आशा वर्कर है, उन जो अभी भी वो बिल्कुल वर्क तो सभी करें, लेकिन कुछ है कि ठीक है सर, डिले क्या होता है कि मैंने आइडेंटिफाइड किया सिम्टम को और उनको इन्वेस्टिगेशन के लिए स्पूटम किया, वो पेशेंट को मैं हर रोज बुला नहीं सकता हूँ कि मॉर्निंग स्पूटम लेके आइए, फिर कल इवनिंग का 24 आवर्स का लेके आइए, उसके बाद फिर सीट, तो वो हमारी आशा वर्कर लेके, उनको पेमेंट नहीं हो रहा. इसका रीजन ये है कि अकाउंट मैनेजर डैम है और उनके पास अकाउंट में पैसे है, 4 बार ऑफिस से फाइल जाएगा तब जाके पेमेंट होगा, नहीं होगा उसकी गारंटी नहीं है। तो पाकुड़ डिस्ट्रिक्ट और भी अच्छा नोटिफिकेशन कर सकता है और टीबी एलिमिनेट सबसे पहले इंडिया में कर सकता है अगर इस चीज को सोल्व किया जाए।
ग्रेट पॉइंट। सो आपने डॉक्टर एहतेशाम एक और बड़ी सी प्रॉब्लम आइडेंटिफाई करी है। कोई प्रॉब्लम्स अपने कंट्रोल में रहती है, कोई प्रॉब्लम्स डायरेक्टली अपने कंट्रोल में बट इनडायरेक्टली। So this is an important idea that how do we get the system to release the money that is due to us? And yes, we will have to work with our senior levels and try to take that approach. That is something that we really have to think together with the STOs as well and come up with a collective approach. DTOs can begin to think and work a process. It will take paperwork, but it is something outside our direct domain. पर आपने बिल्कुल पॉइंट करा है, वो भी अपन को करना है और करना है। दूसरा पॉइंट मैं ये बोलूँगा जो डॉक्टर मोहन ने बोला, to get the welfare ministry involved. In fact, just last week, I had a chance to meet with the Madhya Pradesh's tribal welfare ministry's IS officer, and we discussed many topics of how to move things at in the tribal level in Madhya Pradesh. So these are ideas once when we are connecting with the ministry that we can gently pull up and request that this be addressed. It may not be addressed overnight, thoda time lagta hai ye karne mein, but apan persistent रहेंगे, then it will work. And I, in my capacity also, will certainly bring it up in my senior leadership meetings I do as well. So
thank you.
Yes, Commodore Raman, and this is the data that we can see from Pakur district, and you can see that there is potential for growth. You are clearly going above the baseline now, and that you can be there sustained. Now, many people ask, how long will that be? You will see notification keep staying up. If it stays up for a period of 3, 4, 5 months, and then you will automatically see decrease in transmission, and then it begins to come down over the next 6 to 12 months as well.
Absolutely.
So that is what we need to do. Get it up, boost it, keep it up there, and then automatically it will come down, because that's the nature of the disease. COVID में भी wave होती है, आप सोचिए, COVID की wave 2-3 महीने की होती है. It's 2-3 months COVID wave. However, the TB wave is 20-30 years. It is months and years long. And we are beginning that journey of letting it peak and then making it come down through its natural process by stopping transmission, by early identification, by notification.
Absolutely. Thank you. Thank you, Dr. Ehtashamuddin. And obviously, your data is indicative that you have breached the 2019 notification. It is indicative that you have breached all the targets. It's a wonderful show going, but don't let the focus go, because data thoda niche bhi jata nazar aa raha hai. Apni team ko buland rakheं, motivated rakheं. And मैं काउंसलर और QIC को रिक्वेस्ट करूंगा, इस डिस्ट्रिक्ट को फॉलो करें. यहाँ से हमें सीखने के लिए बहुत कुछ है. There is lot to learn from this district. What are the good methods happening? What are the best practices happening? It is not a very metro city. It is not a very literate or educated place. It's a small town of a not a very forward state. So there is much to learn from this district. And thank you so much. And
I want to thank Sejal and Ankita, our counselors and team leads. Great job.
Absolutely, absolutely. And now we would like to invite, we have 8-9 minutes, but Dr. Esther had actually requested me to bring her at 3/4. But then, we had a requirement to keep this thing going, the sequence. Dr. Esther, if you're there. DTU West Garu, are you there?
I don't see her actually.
I know, Edwin. I read your message. That's why I'm asking.
She's here, West Garo Hills. Dr. Sangma? Actually, she had prepared a lot,
I know. Why do you think I'm calling her at 5:54 p.m.? I know. Just
Ma'am,
check up.
can you unmute yourself?
Yes, we
Okay,
can hear
she's
you.
there. She's there. Dr.
Excellent.
Manoj, and all the DTOs I will request this PDSA must go through.
Yes,
She's
please.
connected from Meghalaya. The weather may go bad anytime. So without
Sure.
wasting any time, Sadaf, please present the PDSA. And Dr. Sagba, welcome. Please present the PDSA.
Hello, everyone.
Hello.
I'm Dr. Esther Sangma, DTO of West Garo Hills, Meghalaya. My district has a population 8.2 lakh, and my monthly target is 76. Now I'm going to change notification 2% in 2 months. And actually, we are achieving the target. In the month of January, we notify 50, and February 66, March, but we notify 92, and April 89, and May 72. So we are getting more than target in the month of March and April, sir. And I'm planning to do the more active case finding in the remote areas and vulnerable areas. My place also difficult terrain, it's a hilly area. And active case finding is going on, but I'm planning to intensify more. And during my field visit, I used to see the ASHA workers having TB. That's why I'm planning to screen all the ASHA workers, because they are the one only treatment supporter, and they are the one direct contact with TB. So we are planning to screen all the ASAs, and I'm planning to conduct more awareness program with the religious leader, community meeting, and school program, and sensitization of medical officer and health worker is a continuation process. We are sensitizing again and again. And I'll try my best to notify more than 2% of the target given.
Excellent.
And outcome measures, whatever we entered TB notification in the NICSHE, we will maintain the cure rate and try my best so that there will be no defaulter and failure. My team members are myself, my MOTCs, TB health visitors, district program coordinator, and ACSM coordinator. We will work together to fight against TB and to make our district TB free, sir.
Excellent. Dr. Lisa, thank you so much. I like your PDSA. I think your several areas you've done great work, beautiful pictures of your field work. I look at several things. One, you've got the outcome and process measures, which are good. In your team, you have also included the TBHVs. You've engaged them. Some people have also done, very interestingly, is in their team, they have added patients. We've talked about that idea of champions. Patients who are formal TB patients, they become champions. Sometimes in a team, when they're joining, they are able to give insights that others may not have. So that is another idea that you can incorporate as you build your team. The fact that you have religious leaders and conducting meetings with them tells me that you're going beyond just the usual, going to the MOs, going to the ASHA workers. You are going into the community. That gives me great confidence that you'll be able to work with the NGOs and others, because they are able to attract those people and spread the message. So very, very nice set of measures that you have done, and sort of a good learning lesson for all our DTOs as they do their interventions as well. So thank you so much. Commodore Raman, we are coming to our hour-and-a-half completion. What a wonderful, wonderful conversation we've had over the past hour and a half. Cannot thank enough to all of our counselors, and the last set with Raj Kumari and team lead Sadaf. Great session. And then we'll see how we bring all of that in. So great work.
Thank you, Dr. Manoj. Thank you, Dr. Sagma. Thank you so much. And it is 6 o'clock now, and we have only taken the time from 4:30 to 6 o'clock from the DTOs, and everybody's time is absolutely very precious. 4 more PDSAs were planned today. My apologies to Dr. Devender, Dr. B.M. Chauhan, Dr. Bhanu. Dr. Bhanu, I know I have been told, Srishti has been advocating your cause that your PDSA must go through today. I promise you, sir, next time in the first 20 minutes, we'll take it. And Dr. Ravindra Tate, counselors and team leads, please convey our personal apologies. We'll make sure that next weekend, straight away. In fact, we are supposed to inform Dr. Manoj whether we'll be having a session next week or not. Go ahead, please.
Yes, I think we had said that we were going to skip next week's session. We will take a break. I know that many of you are working on the PDSA. In fact, I am also traveling. India next week. Today I'm leaving for API meeting, doctors, physicians, with the ambassador, the Indian ambassador to the US. Have a presentation with him, and then I take a flight and I'm in Delhi for 4 days, meeting with some of the DTOs. As you know, we do an I Defeat program, and which is a union and USAID funded program, which has been a great learning lesson for us. Also meeting with DDG and ministry level folks as well. So we will skip our
the session on 1st of July. That is Friday. So all counselors, team leads and DTOs, one session we will miss in between. That is on 1st of July. Okay. But the engagements with the counselors and the weekly meetings will continue. It is just that the session will not happen.
Yes.
So please continue with the good work. And Dr. Manoj, I think all it remains is to now thank everybody for their presence and time. Thank you, DTOs. Please switch on your videos. Give us a wonderful smile. It is time to take a photograph. And thank you, everybody. Thank you, CTD, Emory, WHO, IIPHG, wonderful DTOs, all you wonderful counselors, you're doing a great job, and the team leads, staff, IT of CTI. And thank you, Dr. Mohan, Dr. Manoj, for a wonderful session. Thank you so much.
Namaste. Thank you so much. And we'll see you in 2 weeks. Great work. Continue the great work, everyone. We are making a difference to make India TB free.
And keep looking at your data.
Yes.